Okay, can you hear me? Thank you. Okay. So my name is Ken Wiley, and our speakers today is Karam Diaby, Megan Doerr, Josh Plavin, and Mira Irons. And for our discussion, this will... Right here? Yeah. Did it now? Okay. So here we go. So we've covered a lot today, but another section we want to talk about is what we have is a list of questions that we want to ask the speakers here. Our first question is, from your perspective, what is our number one need for implementing genomic medicine in the next 5 to 10 years? Who wants to go first? You? Okay.
Sure. So over the past few days, I've been thinking a lot about this, and I worry about how can we scale this across the healthcare system. How can we take what Marc and his colleagues are doing at Geisinger and what Peter Hulick and his colleagues are doing at North Shore and scale that, and what are the necessary components of that? We know what the pain points are. We've known what the pain points are for the last 10 years. There are over 77,000 genetic tests out there. People don't know the difference between those tests. The payers don't know what to pay for. The doctors don't know what to order. In the end, the patients don't know that they're getting the right test that they need. On the other hand, we've got kind of this shadow healthcare system out there also with direct-to-consumer testing, so that patients are getting tested for anywhere from 20 to 30 to 59 to 147 disorders. And I think that what it all comes back to is evidence of benefit and utility. In the end, that's going to drive the process forward. And so if, when I think about what NHGRI can do is to try to gather this evidence, gather the evidence of and I specifically don't say clinical utility. I really focus on utility, both from the medically actionable side to social to personal, and also economic utility. Because in the end, someone's going to ask that question. How is this just going to increase healthcare costs over the next 5, 10, 20, or 30 years? Or, to Mike's point, can we decrease healthcare costs by not screening everybody for everything? But gathering that evidence is going to start now. So I will, I'll settle on evidence here.
So I would agree and support that. I'm a rural primary care physician and the CMO at Blue Cross in Vermont. And so I think about my patients and how am I going to implement this information? And Marc made a comment about just-in-time education. I think to myself, how do I learn? I go to multidisciplinary rounds, I go to CMEs, that's great. But really, I learn by seeing patients. And I learn by looking at, and quite honestly, on UpToDate or Dynamed when I don't know something, or I call a friend. And so having kind of that just-in-time overlay is going to be important. Plus, it also could support patient research, I would imagine. And with new technologies, fire an API into the EMR, allowing clinical decision support technologies to be in my workflow as I'm seeing patients. I could imagine a future where I would both be learning, but also contributing to a research initiative. And at Blue Cross, in general, we are moving, like Medicare, towards evidence with coverage determination. So partnerships with payers, we really would love to know if there are opportunities where we can better identify populations that don't benefit from kind of broad universal screening. I see a future, and I think you guys do too, where screening is much more targeted towards the individual epidemiologically and genetically as well. So, and we are very focused on outcomes, and I know ICER is going to be very involved in this type of work and inform payers, and most of the payers, quite honestly, don't know what to cover. They refer to vendors or basically partners, vendors call like Concert Genetics or Avalon or some others that are quote unquote subject matter experts that support them, but partnerships with them as well based on kind of a national research and data repository would be quite interesting.
So from my perspective, we are really at a critical decision point. Our field is relatively young, and we have seen already in just our few decades of existence through Malia Fullerton's damming diagram how white our research has been. And if we do not take the time now to change our course, we will only further cement the haves and the have-nots in the world of medicine. And so the All of Us research program is doing a lot to develop some of the, to gather some raw genomic data that can be used for solving. I think we also need to think about how do we create clinical pathways that work not just at high-tier academic medical centers, but work at federally qualified health centers. How do we use promotorists, for example, public health workers, to promote genetics in all sorts of different types of diverse communities? Because we need to make sure that we have pathways that will work in the clinic so that when we actually have the evidence to support genetic intervention in non-white populations, we're ready for it, rather than there being then an additional gap, an additional wait time between the evidence emerging and the implementation happening. I really feel that this is a moral and ethical imperative. I also feel like it's a scientific imperative. I also feel like it's a clinical imperative.
Thank you. And I would agree with what the former panelists talked about. I think one element that we didn't really emphasize over the past 2 days, and I think Marc and others pointed towards that, it's value demonstration. So how can we be implementing something that we don't necessarily know about the value? So developing a discourse that is going to be common across different programs, meaning talking about the definition of outcomes. So how do we get together and have the same definition of, for example, utility? We talked about utility. As an economist, utility to me might mean something different for a clinician. So utility is basically satisfaction. It's a concept that is linked with satisfaction. So my satisfaction is going to be different than a payer. So we have different actors in the healthcare system. So we have the payers, we have the patient themselves, and we have clinicians. So if we don't define the perspective or the lens, within or through which we're looking at the implementation, we're not going to be communicating very well. So for me, we have to define the perspective. So from a payer perspective, value has to be defined, and the elephant in the room is economics. So how do we develop measures from a methodological perspective to really establish the value of genomic and, let's say, NGS, for example? So for me, value demonstration is critical to implementation, and if we're not really ready to have that discussion, then I think we're not ready to do implementation.
Thank you. So our next question is, what would the world look like if we didn't implement your number one idea? So I'll just go through the same order we started.
Sure. So I think there are some of us in the room who go back to the early days of molecular testing. I was a fellow at Mass General when Jim Gazelle identified the chromosomal location of Huntington's disease. And I remember thinking that, at some point, what we learn in genetics and genomics, we didn't even know about genomics then, is going to move past the treatment and identification of rare disease into broader healthcare. And I think that if we don't implement, if we don't learn how to scale this at this point, and if we don't gather the evidence of value and all agree on outcomes, we wouldn't have fulfilled that promise. Because I think that there's going to be huge pushback on moving it out of rare disease. The doctors won't know what to order. Payers won't know. Payers will just not pay for the testing, and we're going to be spinning our wheels the way we really have been over the last 5 years. So I think that we're at this pivotal point where we're really moving healthcare out of treating disease, identifying and treating disease, to trying to prevent disease. And I think we have a huge opportunity here. But if we don't really take hold of this at this point, we won't have achieved that goal.
There's a proliferation of access to clinical genomics through labs, basically, and I'm concerned that we see a lot of talk about academic approaches to the transfer of information, translational, et cetera, but out in the community, people are utilizing clinical genomic data appropriately and inappropriately, and I think that will proliferate. It's already proliferated on the direct-to-consumer front, where patients walk into my clinic with their tests, or I have to have the discussion around variants of uncertain significance with them. And I think it's a bit of the Wild West, and I worry quite a lot. We see a lot of the potential financially for people to be balance billed for tests that are done that are not covered or covered partially, which are in the thousands to tens of thousands of dollars, and I'm quite worried about that piece of it economically. So if we don't get to the value, as you point out, and how to build a kind of standardized approach to this, I think we're just going to see rampant abuse.
Can I just add on to that? I think that we're also at a time where burnout is at an all-time high for physicians, and prior authorizations are a huge part of that burnout. And to your point about genomics being done in the community now, it's just going to lead to people having more imaging, more diagnostic testing at ages or stages of their life where that wasn't common practice. And, that will end to just more prior auths and more patients getting balance billed for things. So, somehow taking control of this is going to be really important.
So my concern, if we keep on with a non-diverse population being served by our profession, is that machine learning techniques, clinical decision support, artificial intelligence are going to become more and more a part of the practice of clinical genetics. And if the data that we use is biased, the outcomes that we use will also be biased, and this bias will calcify, will ossify within our system, and will make it virtually impossible for us to create any form of health equity. And so machine learning, I think, is really going to be critical over the next 10 years. And so recognizing the biases that are inherent in the data that exist within electronic health records, recognizing the biases that exist, which are in any large big data sets, will be really critical for us to carefully navigate as we try to put supports in place to help facilitate genomic medicine, but without, if we don't address this, the whiteness of our data, we're stuck.
Thank you. I think if we don't necessarily assess or demonstrate value of, let's say, NGS, for example, what we're going to end up doing is implementing or using or adopting those technologies without necessarily knowing whether it's sustainable over time. And sustainability is very important in our healthcare system. So this is something that we cannot necessarily afford doing without knowing what the value of those technologies are. So I think definition of outcomes, understanding the metrics to do the evaluation, and developing methods appropriately for assessing the value of NGS, for example, I think is critical. So if we don't have that, I'm not sure how we can actually achieve the goal that we set for ourselves.
So our third question is, how did the ideas expressed yesterday and today fit with your vision of genomic medicine?
So, I think that it was a small part of it. I think a lot of our discussion over the last day and a half was really more focused on sort of the academic medical perspective on genomic medicine and research and implementation. And, my goal is for a much broader perspective on this. But especially to Meg's point, several months ago in Chicago, it was noted that if you lived in Streeterville, which for those of you who know Chicago is sort of the northwestern, North Michigan Avenue, Navy Pier end of Chicago, your life expectancy is 90. And if you live in Edgewater, just 9 miles south of Streeterville, your life expectancy is 60. And so reconciling this issue of, zip code versus genetic code and the social determinants of health is really important. But I actually think that genomic medicine, my vision is that it can actually help bridge that gap if we're smart and we implement it responsibly and we get with the data that we need.
So I think a lot of the ideas that I've heard, and unfortunately, I apologize, I was not here yesterday for travel issues, but a lot of the ideas that I've heard are important from the perspective of developing the workforce of the future and work within highly regimented systems of care that don't exist in much of the country. And so, again, I'm trying to figure out how to apply this to my rural clinic in Chelsea, Vermont, and in a disciplined fashion. I do think that NHGRI can serve a really important role of the convener and facilitator of both the research and implementation research. Of both the content, but also the application of that content to change my behavior or providers' behavior in the field. Unfortunately, I am a 50-ish-year-old primary care provider, which is pretty much the standard age in the United States. And so we will have a generation in 10 years that is moving on, and we don't have enough of us kind of coming up to replace, thank God for nurse practitioners, us. We are going to be tough to change in terms of our behaviors.
There were many things yesterday that really struck a chord with me when I think about genomic medicine. I think one of the themes that came through to me was the communitarian nature of genomic data, and that genomic medicine is really a practice of communitarian medicine because it needs to be, because cascade testing and because families are the unit of analysis when we think broadly about genomic medicine. And so I was really happy to hear that communitarian nature recognized. I think we struggle against a system which is designed for individual care. All the regulations are around individual privacy. All of our training is around individual people. But genomic medicine is a practice of communitarian medicine. It has to be because of the nature of what we're looking at. And so really the speakers in theme 4, I think, were hitting on that hard enough, this multi-generational genomic education, cascade testing and outreach, the idea of all of Carol's ideas for NHGRI grants, looking at literacy level and not only English and giving back community benefit, I think is also really powerful. And also the PGX needs to be inclusive. All of that idea of inclusivity, communitarian basis of the community as a unit of analysis, and the community as a unit of engagement, and the community as a unit for considering what is value. All were things that I really appreciated about yesterday's discussion.
Thank you. So I think if there is one thing that this workshop kind of made us realize is tackling a question like this has to be done in a holistic manner. So there is not just one perspective to how to implement genomic in medicine. And I like one of the ideas that were brought up yesterday, and I think that's what PCORI is kind of implementing in terms of research. So to NHGRI, I think developing research question that would have some of the components of the PCORI process, which means basically having all the stakeholders at the table at the time of developing the question until the dissemination part of the research. I think that is really, really important if we want to be successful in implementing genomic in medicine. So I think yesterday we talked about a lot of interesting points from measuring until dissemination. So I think it would be important to adopt a process that bring all the stakeholders together in order for the question to be answered properly.
Thank you. And I'd like to add something also for number 3. Calm down. One of the things I've realized in listening to from yesterday and today's conversations is really amongst all the concerns and the barriers that we face in implementing in genomic medicine, one thing that's consistent is that, at least just hearing today and even, in my experience, is that genomic medicine really does play a significant lead in pushing the concept of preventive medicine. And I don't think we really give it the respect it deserves in that. As we're making this transition from procedural to preventive, which is a significant transition, one thing you realize with those who are really dedicated to the procedure ones, and even the ones pushing for the preventive ones, they all agree that genomics plays a role in that. And that should be acknowledged. With all the stuff we have going on, that is one of the, that's something that we can all agree on, which is, as you know, in the healthcare profession, that's a rarity. So I'd just like to highlight that for number 3. So for our 4th question, is there anything we missed in discussions over the last 2 days?
So I think 2 things, and the first is this whole issue of an evidence framework and levels of evidence. I think that physicians trust the tools that they use. When I get the CBC report, I believe that hemoglobin is probably within, standard error of what the patient's hemoglobin is. And a lot of that trust has been built up by evidence frameworks that in pharma and in other areas rely on randomized controlled trials. And I think in the area of precision medicine, like AI and like digital health, we're moving into a different type of sort of N-of-1 research. And what are the evidence frameworks that are used for those, what I call disruptive tech-enabled innovations? And what are the levels of evidence that are needed in order for a physician, a healthcare provider, a patient to trust the results that they get from that? That's actually a discussion that needs to be convened nationally that NHGRI, I think, could play a role in. The other thing we haven't heard in the last 2 days, and I am a bit frightened to even bring it up, is GINA. And this whole area, this whole issue of discrimination in an era where pre-symptomatic testing is being done, and whether payers will potentially interpret pre-symptomatic testing as being diagnostic or symptomatic in some way. And so I always worry about discrimination, and I worry about, and I know GINA doesn't doesn't include life insurance and disability and other insurance, but there is a move in several states to add that onto GINA, and the insurers are just going to look sort of at their actuarial risk tables, and how preventive or pre-symptomatic testing is actually going to change that. Because identifying something at an earlier age or at a time that you could potentially treat it is going to change that, but we're going to be in this middle, intermediate time when we don't know that.
So yes, I'd echo that, and the clinical economics as well as the behavior change that will need to occur. So as we get into the area of risk profiles at a preventive level, I need to know, where the genomics of my population is, what the environment, the SDOH, and epidemiology, but I have to know what their individual behavior patterns are so that I can modify those behavior patterns, or is it modifiable? And so knowing the information actually and having the impact on outcomes by changing behavior potentially is going to be part of, I would imagine, a research question. So health plans cover all of the preventive services by USPTF, but those are pretty well borne out in terms of both outcomes impact and the clinical economics of them. And so we'll need to do the same along those lines, I would imagine.
I agree, Gina. The patchwork of regulatory shenanigans that we find ourselves in right now between GINA, HIPAA, the FDA, the FTC, the FCC, and their lack of combined recognition of the big data environment that we live in, I think is going to become a major issue for us here at NHGRI over the next 10 years. Right now, we're starting to see organizations like Trend Community, which is an online group that's, it's a company that's mining online groups, discussion forums using natural language processing to pull out phenotypic symptoms associated with particular mutations. And then they are selling this data to pharmaceutical companies. They live in a completely unregulated space. They're mining data off of Facebook. This is happening outside of clinical care, but it is one of the growing major sources of phenotypic data that is being used to develop therapeutics. And we haven't talked about that. And the regulatory environment that we're working in doesn't address this. And we are myopic as clinicians, not recognizing that the practice of genomic medicine is happening largely outside of the walls of our hospitals. To that end, deep phenotyping and mobile health are really going to be increasingly important over the next 10 years. I think we mentioned this a couple of times in the discussion that's happened this morning. The importance of structured ontologies, I think, is going to become even larger. Those structures ontologies need to be international, and they need to be inclusive. The data is not anonymous. We need to stop talking about it being anonymous. And then how do we measure value, which is something that's come up in this discussion. Again, trying to understand value at a community level as well as an individual level, and also really taking into account the psychosocial benefits as a form of value, which is a different perspective, but I think a really necessary one. That's a growing recognition that we have, that we're starting to have in medicine, that, the same medicine in different people can have different impacts, and the same treatment in different people can either be life-saving good or life-altering bad. And that has major impacts for clinical outcomes, starting to have a much more nuanced and rich understanding of how we measure value.
Thank you. Well, I'm going to repeat myself again. like I said before, I'm an economist, so I'm really interested in resource allocation and value. And value, the definition of value is very complex, and I think tackling that is really important. So over the past 24 hours, we did a great job at talking about the clinical or clinician perspective, a little bit of patient perspective, but not that much, and also missed opportunities, the payer. And when we talk about implementation, we have to talk about adoption, and adoption goes hand in hand with coverage and reimbursement decision. So obviously, from my perspective, we didn't necessarily do a good job at talking about value economics and what that means in that context. So, yeah.
So I'd like to thank our panelists for their time, and we want to open up. Yeah. So we open up to the general audience.
So I wanted to bring up something that I don't think has really been brought up yet, which I think NIHGRI really may need to take a look at, is how are current kind of study sections playing a role in kind of what continues to get funded. Some of the things that we've heard about are needs like for more engagement with community, but kind of without the metrics of that, and what does that look like? And in terms of funding announcements, community engagement takes time. And those projects don't necessarily, they may be delayed in starting up because you're co-designing kind of the project with the community, and the current timelines really don't allow or really reward that time, which then can impact when you're publishing and all of those other things. So I think taking a look at kind of that infrastructure and how it may or may not be supporting where the work needs to go in the future, I think is important. Study sections, like for instance with PCORI, have patients on them, but the current study sections within NIH don't include, they include scientists for the most part. The other thing I also kind of hate to bring up, because I don't know the logistical way to fix this, but in terms of consent and permissions, people's preferences and what they want, may or may not want done with their data is going to shift and change over time. But right now, kind of a lot of our systems are really set up where that's like a one-time thing, and then we just assume people want that for their lifetime and past their lifetime. So just a couple thoughts.
Mark?
Yeah, one of the themes that's emerging is clearly around the issue of privacy, discrimination, and risk. And I recognize that my position is somewhat discordant with, I think, a majority of the opinions expressed in terms of my view of risk. But I would make two comments. One is that, again, I think we need to establish a study of the unintended consequences of being overly focused on privacy in terms of harms from not sharing information with individuals and with relatives of individuals, because there are consequences that are tangible. And I think if we only focus on the risks to the individual of a privacy disclosure, that we're going to be missing those potential harms. So that would be one aspect of it. I think the other thing, though, is that a lot of the things that are expressed I do agree with, which is it's unlikely we're ever going to be in a situation where we can protect against all inappropriate disclosure of this information. And it's also unlikely that we're going to realistically be able to have de-identified or anonymized data. So I think that the role that I see for NHGRI related to that is a policy role, which is to say, can we define tiers of risk? What information is perhaps very low risk? The risk of harm to an individual would be extremely low, whereas there are others that will probably be extremely high. And what are the necessary protections around that data? And more importantly, what are the consequences to breaches if people do something inappropriate and do re-identification, what does that mean for them in terms of their ability to participate in NIH-funded research? So those would be two things that I'd like to see enhance the discussion and research agenda on privacy.
Bob?
Thanks. I did want to try to get a little bit more granular about the idea of having all the evidence before you do an implementation. And I think that in reality, the quality of the implementation affects what the value that you get out of it. So I think it's really hard to say, okay, we've done this research study in a controlled environment where we implemented it one way because we thought the way it was, and we had to stick with that implementation through the whole thing. And because that was how we defined it, we couldn't iterate and improve through that period. And we come out with a value that's insignificant or not convincing. And that's really different than the way things happen in the real world, if they're done right, is that you begin an implementation carefully with what you think is the best thing, and you iterate continuously. And when you get to a point where the iterations aren't making any difference anymore, then you may have reached your endpoint and say, okay, it's okay, there's no value here. But I think that it's unrealistic to say, well, we're going to get the evidence that says there's value before we do any implementation at all.
So can I just respond to that? To be clear, that's not what I was saying. What I was saying was that we needed to begin gathering evidence, because we've gotten to the point now where, because there are so many tests out there and so many people are ordering tests and using them differently, that many of the payers are just saying, no, I'm not going to pay for any of it. I wasn't responding so much to that as to Karam's statement about that, and maybe I misunderstood his intent. Yeah, no. And I think we have to start gathering that evidence, because at some point it's going to help inform our practice, if nothing else. So that's a discussion that we just all have to have together.
Yeah, and I guess what I'm proposing is to gather that information and do those studies in the context of an implementation. And continuous learning, yeah.
One quick thing that I forgot to mention explicitly that I wanted to just get on the record was metadata harmonization as an important thing that we haven't talked about, which kind of goes along with the standardized ontologies, but I just wanted to call out the importance of spending time doing metadata harmonization so that we can use these data sets effectively.
Yeah, if I can respond to your comment. So the concern that I had is this. So there are technologies that are being produced, and payers have to make a decision. So where do you actually decide? At which point do you decide that you have gone through all the iterations that you could possibly do in order to be satisfied with the implementation, and then actually move on with that? So my point is there's a lack of approaches to kind of evaluate and then provide some types of evidence to those payers. And also from a patient perspective, how do you define that value? So that's the point I was making, but there is no timeline per se where you're going to say, well, after X amount of time, we can actually talk about the value of the technology. So that happens, real time, kind of.
Right. So when you said implementation, you really meant, when are we going to pay for it?
Yes. Yes. In the definition of implementation, I'm talking about adoption. I'm talking about yes.
Patrice? Or do you want to respond to that,
I just
Mira?
want to respond, because in the end, when are we going to pay for it really makes a difference, because the patient gets stuck with, you have in the end, you have a clinical encounter. You have a healthcare provider, whether it's a physician or a nurse practitioner or a PA, and a patient sitting in a room, and you're having this discussion about, I think, I'd like to order this test. I think it can help you. And then, you get a 1 month prior auth process that says, no, I don't think this is indicated. So in the end, you've heard, you've accomplished nothing and heard everybody in the process. And so I think that when will it get paid for is important in this whole discussion. And it's
So
an
I guess
equity
maybe one of the
issue,
checks-
because it's absolutely an equity issue, because I think we've all had patients that will say, well, balance bill me, and this is important, and I'll pay for it, and that's not right either, because it is a huge access and equity issue here. And this all goes into narrow networks also. Patients see doctors that are in their network, the lab gets sent to a out-of-network lab, and patients get $6,000 in billing. So I think, this is all part of the how are we going to make this work process.
Right, so can we phrase that the challenge is as how to fund that phase that's between, a hardcore research study and the point at which payers see the level of evidence as sufficient.
Great. Thanks for that, Bob. We have to wrap up.
So thank you, everyone. Have a nice day.
So now is going to be your chance to be able to follow up on where you might have some differences in opinion between what everyone has heard so far over the last 2 days. And so we're going to have Jyoti introducing the brief interactive that we're going to ask everyone to be able to complete over lunch. So we have 2 different interactive activities we would like you to be able to complete. Jyoti's going to tell you a little bit about the interactive questions, which is the longer survey, and then we're also going to be asking you to be able to follow up on the barriers and opportunities that everyone completed yesterday to be able to see if anyone's changed your thoughts. And then we'll discuss all of the results after lunch. So Jyoti?
Okay, great. So as Anastasia said, we're going to transition now into the interactive discussion. So we want to think about things a little differently from the perspective of a foundational resource, barrier, and audacious research goals. So we have definitions on the website, but foundational resource is a resource needed to make genomic medicine happen. Breaking barriers, issues that need to be overcome to make genomic medicine happen. And audacious research goals, major research questions that needs to be addressed to make genomic medicine happen. And then the second set of questions, should NHGRI be involved in training healthcare providers and therapeutics research? So we have touched on that a little bit over the last day and a half. And we'd also like you to complete the barriers and opportunities number 2 questionnaire. So it's the same one as yesterday, but it's revised and what you see differently from yesterday and today. So lunch is outside. Is there a question?
Next slide, we'll get to the...
Okay.
That has the website one more.
There we go. There's the website. Okay, great. Thank you. So lunches are outside. Again, you're welcome to stay in here or go into the conference room right next door. If you don't have a tablet or computer or device, we do have one up front here. And we'd like to have the surveys completed by 12:15 so we can gather results and present them in the afternoon. Any questions?
So what on the website? Somebody needs to, there we go. What on the website are we answering? There's a barriers and opportunities.
Yeah, so there's it's a link for interactive session and barriers and opportunities number 2.
Excellent.
Okay, I think that's it. Thank you.